You're lying on a gurney, staring at a ceiling of flickering fluorescent lights. Maybe that's happening tomorrow, maybe it's next week, but right now, in this moment, there is a cold, gnawing sensation in the pit of your stomach. It's fear. You're terrified, and I know exactly why. It's not the surgery itself that haunts you. It's the loss of control. It's the idea of handing your entire existence over to a stranger while you descend into a void where you can't fight, you can't scream, and you might not even remember who you are. Most hospitals give you a brochure. They give you the sanitized, prepackaged version of the truth. They tell you that you'll go to sleep and wake up refreshed. But you and I both know that's a lie. General anesthesia isn't sleep. It's something much closer to death. It is a chemically induced coma where your most basic human functions are hijacked by a machine. I'm Dr. Michael Kent. For 15 years, I have stood at the head of the operating table. I have chemically eliminated the consciousness of thousands of people, and I have fought to bring every single one of them back. I've seen what happens in the gaps of your memory. I've seen the moments where the line between life and death becomes so thin it's almost transparent. Today, I am stripping away the hospital curtain. I'm going to tell you exactly what happens to your brain, your body, and your soul when we turn you off, because you deserve to know the truth before you close your eyes. Let's start with the ghost story that keeps you awake at night, the one question you're too scared to ask your doctor because you don't want to sound crazy. Will I wake up while they're cutting into me? It has a name, anesthesia awareness. And I'm not going to sit here and tell you it's impossible. It's not. It happens. But before your heart rate spikes, I want you to look at the forensic reality of it. We estimate it occurs in about 1 to 2 cases out of every 1,000. That's a fraction of a percent. Statistically, you are more likely to be struck by lightning while holding a winning lottery ticket than you are to experience true awareness during surgery. But for those 1 or 2 people, the reality is a psychological horror film. They describe a sensation of being locked in. They can hear the clinking of the surgical steel. They can hear the surgeons talking about their weekend plans or complaining about the hospital coffee. They can feel the pressure and sometimes the searing heat of the blade, but they are paralyzed. The drugs we use to keep your muscles still prevent you from so much as fluttering an eyelid. You are a conscious mind trapped inside a dead weight, screaming in a vacuum. We have monitors for this. We track the electrical noise in your brain, something called a BIS monitor, to make sure you stay in the deep basement of unconsciousness. We dose the medications with surgical precision based on your height, your weight, and your history. But medicine, despite all our machines, is still a human endeavor. It isn't perfect. And that is the first truth you have to accept. When you go under, you are stepping onto a bridge that we built, but a bridge that spans an abyss we still don't fully understand. Think about the room for a moment. If you've ever been in an operating room, you know it's cold. It's always freezing. There's a medical reason for that. Bacteria don't thrive in the cold, and the surgeons, under those heavy gowns and hot lights, need to stay sharp. But for you shivering on that thin mattress, the cold feels like a warning. I'm standing right there at the head of your bed. I've read your chart. I know about your grandmother's heart condition. I know about that allergy to penicillin you had when you were 6. I know your fears because I can see them in the way your pupils dilate when the nurse starts the IV. I'm about to perform an act that is both miraculous and, frankly, terrifying. I am going to chemically manipulate the very thing that makes you, your consciousness, that spark of awareness that allows you to love, to remember, and to exist. I'm going to flip the switch, but it's not a simple toggle. It's a carefully orchestrated chemical symphony. It starts with the pre-med. Usually it's a drug called midazolam. You might know it as Versed. It's a benzodiazepine, a cousin to Valium, but much more aggressive. Within seconds of it hitting your vein, the world starts to soften. The sharp edges of the room blur. Your anxiety doesn't just lessen, it evaporates. But here is the unsettling part that we don't usually emphasize. Midazolam causes anterograde amnesia. This means your brain effectively stops recording. You might still be talking to me. You might even tell me a joke or ask a question about the surgery. The nurses might laugh. You'll feel perfectly fine, but 10 minutes later, that version of you will be gone forever. You won't remember the joking. You won't remember being rolled into the OR. Your brain simply stops writing the story of your life while you're still awake to live it. Then comes the induction. This is the moment of no return. I'll tell you to take some deep breaths of pure oxygen through a plastic mask. It tastes like nothing, maybe a hint of medical-grade plastic. We call this pre-oxygenating. We are saturating your blood with every molecule of oxygen we can find, because in about 60 seconds, you are going to stop breathing. Your lungs will go still, your diaphragm will quit, and I need to buy myself enough time to take over for you. Then I reach for the syringe of propofol. If you've seen it, you know it looks strange. It's not clear like water, it's a thick, opaque white liquid. In the medical world, we call it the milk of amnesia. It is the most powerful tool in my kit. As I begin to push that white fluid into your IV, I'll tell you to count backward from 10. Most people don't make it to 7. As the propofol travels up your arm, you might feel a sudden intense burning. It feels like your vein is on fire. That's normal. The drug is highly alkaline. It's literally irritating the pain receptors in your blood vessels as it rushes toward your heart. But you won't care about the pain for long, because when propofol hits your brain, the world doesn't fade out. It snaps shut. 8 seconds, 10 seconds, that's all it takes. Your eyes roll back into your head. Your jaw goes slack. Your body becomes a heavy, lifeless weight on the table, but your body doesn't go quietly. There is a window, a terrifying 5-second gap between the moment your mind vanishes and the moment the paralytics freeze your limbs. We call it the excitement phase. Your brain stem, sensing a total loss of cortical control, panics. It's a biological rebellion. Your heart rate might double. Your blood pressure might skyrocket as your adrenal glands dump a final useless surge of fight-or-flight energy into a system that can no longer fight. I see it in your fingers. They twitch, grasping at the air as if trying to catch the last threads of reality. Your chest heaves in a jagged, irregular rhythm, a desperate attempt to pull in one more breath of the world you're leaving behind. It's the most honest moment of the entire process. It's the animal inside you realizing the cage door has been locked from the outside. I stand there, my hand on your shoulder, watching the monitors scream in digital protest until the chemistry finally wins and the silence takes over. It's a silence so absolute it feels heavy. The monitors level out. The rebellion is crushed. And that's when the real work begins. In that moment, for all intents and purposes, you have entered a state that is biologically indistinguishable from death, save for the fact that I am standing there, refusing to let you go. Now you're you're gone. And this is the part where most doctors would start quoting textbooks and explaining the pharmacology of GABA receptors. But I'm going to tell you something that usually stays behind the closed doors of a medical conference. We don't actually know how anesthesia works. Think about that for a second. We have been doing this for over 150 years. We have put millions upon millions of people into this state. But the actual mechanism, the physical how of how a chemical can turn off a human soul, is still a mystery. We know what it does. We can see the effects on a brain scan. We see the lights go out, but we don't know exactly how the bulb is being unscrewed. The leading theory is something called fragmentation. Imagine your brain as a massive, bustling city. The prefrontal cortex is the town hall where decisions are made. The thalamus is the central train station, routing information from your eyes, your ears, and your skin to the rest of the city. When I give you those drugs, I am essentially cutting the power lines between the neighborhoods. The city is still there, the buildings are still standing, the individual neurons are still firing. There is still electrical activity, but they can't talk to each other. Without communication, there is no whole, and without the whole, there is no you. Your brain stops integrating information. Your eyes might be closed, but even if I force them open, your brain wouldn't know what it was seeing because the seeing part of the brain can't talk to the understanding part of the brain. You become a collection of isolated islands of neural activity, drifting in a dark sea. You aren't sleeping. You are fragmented. You are statistically, chemically non-existent. Time under anesthesia doesn't just stop, it warps. In the outside world, the surgeons might be struggling with a bleeder for 40 minutes, the air in the room thick with the smell of cauterized flesh and the rhythmic beep-beep of the pulse oximeter. But for you, those 40 minutes are compressed into a singular, non-existent point. You are inhabiting a surgical limbo. Think of it like a skip in a digital file. There is no blackness because blackness requires a mind to perceive it. There is no quiet because quiet requires ears to hear the absence of sound. You aren't just in the dark, you are the dark. It is a profound cosmic isolation. When patients ask me if they were dreaming, I often tell them that dreams are too busy for general anesthesia. Dreams require the brain to play with memories. But here, I've unplugged the projector. You are the empty screen. You are the space between the stars. It is the only time in your entire life, from birth to the grave, where your ego is completely, legally, and biologically deleted. You are a ghost inhabiting a machine, waiting for a spark to be let back in. But while your mind is fragmented, your body is still there on the table. And because I've just chemically shut down your brain's ability to send signals, your body has forgotten how to stay alive. The moment you lose consciousness, your tongue relaxes. It falls back against the throat, blocking the airway. Your diaphragm, that big muscle under your ribs that pulls air into your lungs, just quits. It's waiting for a signal from the brainstem that is never going to come. Within seconds, your oxygen levels would begin to plummet. Your heart would start to strain. Your skin would turn a ghostly mottled blue. This is where I earn my keep. I place a clear plastic mask over your face. I use my left hand to tilt your jaw back. It's a specific maneuver we call the triple airway maneuver to open that passage. With my right hand, I squeeze a black rubber bag. I am literally breathing for you. I am watching your chest rise and fall. I am looking at the monitors, watching the green line of your oxygen saturation. I am the bridge between you and the end of your life. But I can't hold a mask on your face for a 6-hour heart surgery. I have work to do. So I have to perform what we call intubation. And if you saw this in a movie, it would look like an assault. I take a laryngoscope, a curved stainless steel blade with a bright LED at the tip. I insert it into your mouth, sweep your tongue to the side, and lift. I am looking for your vocal cords. They look like two pearly white strips of tissue shaped like a V. Once I see them, I thread a plastic tube, the endotracheal tube, straight through those cords and into your windpipe. I inflate a tiny balloon at the end of the tube to seal it off so no stomach acid can get into your lungs. Then I connect you to the ventilator. That whoosh hiss sound you hear in hospital dramas, that's the sound of a machine taking over your most basic biological right. The machine is now your lungs. It decides how deep you breathe, how fast you breathe, and how much carbon dioxide stays in your blood. You have been completely bypassed. But being unconscious isn't enough for a surgeon. If a surgeon is working near your spine or inside your abdomen, they need your muscles to be as limp as wet noodles. Even an unconscious person has reflexes. If the surgeon's knife touches a certain nerve, your leg might twitch, your abdominal muscles might tense up. That's a disaster when someone is holding a scalpel. So I give you a paralytic, something like rocuronium. This drug is a direct descendant of the poison used on the tips of arrows in the Amazon rainforest. It travels to the junction where your nerves meet your muscles and it plugs the receptors. Your brain can scream all it wants for your hand to move, but the message is blocked at the gate. At this point in the surgery, you are a physiologic ghost. You are unconscious. You are paralyzed. You are being breathed by a bellows. Your heart is only beating because I am carefully managing the chemistry of your blood. If I walked out of the room right now, you would be dead in less than 5 minutes. I want you to feel the weight of that. When you see your anesthesiologist in pre-op and they're checking their watch or looking at their clipboard, understand that they are the person who is about to take your life into their hands and hold it there perfectly still for as long as it takes. Now the surgery begins. The lights are bright, the music is playing, surgeons love their music, and the room is a hive of activity. But I am in a different world. I am sitting at the head of the bed behind a blue paper drape that separates the sterile field from the unsterile world. I am not just watching you, I am listening to you. Every beat of your heart is a tone on my monitor. I can tell by the pitch if your heart rate is climbing. If it climbs, it might mean you're starting to lighten, that your brain is sensing the pain of the surgery even if you can't feel it. I turn up the gas. I'm using sevoflurane now. It's a potent anesthetic gas that you're breathing through that tube. It has a sweet chemically smell like a cross between ether and floor wax. But anesthesia is a vasodilator. It relaxes your blood vessels. Imagine your circulatory system is a series of pipes. Anesthesia makes those pipes twice as wide. Suddenly, the pressure inside those pipes drops. Your blood pressure tanks. If it goes too low, your kidneys fail. Your brain doesn't get enough oxygen. You have a stroke on the table. So I'm constantly dialing you in. I give you a hit of ephedrine to squeeze those pipes back down. I give you a liter of cold saline to fill the volume. I'm watching your pupils. Are they dilated? That's a sign of stress. I'm checking your skin temperature. Are you getting too cold? I turn up the forced air warming blanket draped over your legs. I am performing thousands of micro calculations every minute. I am the silent pilot of a plane that is currently in a controlled dive. My job is to make sure the plane never hits the ground and that the passengers, you, never even know we were in the air. While the surgeons are closing the last layer of your skin and I am beginning to prepare for your return, we have to talk about the question that haunts the corridors of every anesthesia department in the world. Where were you? For most of you, the answer is nowhere. You closed your eyes in the induction room and you opened them in the recovery ward. The intervening 4, 6, or 8 hours simply do not exist. It isn't like sleep, where you have a vague sense of time passing or the lingering shadow of a dream. It is a literal skip in the record of your life. But for some, the void isn't empty. I've had patients wake up and tell me things that defy every medical textbook I've ever read. I'm a man of science. I believe in data, in chemistry, and in the electrical laws of the heart. But I have stood by the bedside of people whose hearts had stopped, clinical death under anesthesia, and I have heard them describe things they couldn't possibly know. I remember a man 64 years old undergoing a routine bypass. His heart went into a lethal rhythm, then stopped. For 8 minutes, he was dead. We were doing chest compressions that were breaking his ribs. I was slamming epinephrine into his central line. We shocked him 3 times. Finally, the line on the monitor danced back to life. When he woke up in the ICU 2 days later, he didn't talk about the pain in his chest. He looked at me and said, "I saw my father. He was standing in a place that smelled like rain and cedar. He told me I was early." Skeptics, and I am often one of them, will tell you that this is hypoxia. They'll say the dying brain, starved of oxygen, fires off a final burst of neurochemistry that creates comforting hallucinations. They call it the DMT dump. But then you talk to the patients who describe the surgical instruments we used, or the specific conversation the nurses had while they were dead. What happens to consciousness when the brain is fragmented? Does it stay in the body or does it drift? I don't have the answer. And that mystery is what keeps me sharp. Every time I put someone under, I am reminded that I am messing with the most profound mystery in the universe. I am turning off the lights in a house and hoping the resident stays inside. Now the surgery is over. The drapes are coming down. The surgeon is walking out to talk to your family. But for me, the most dangerous part of the flight is the landing. We call it emergence. I turn off the sevoflurane gas. I stop the propofol drip. Now I am waiting for your body to metabolize the chemicals. I am watching the monitors like a hawk. Your brain activity begins to rise. On the EEG, those flat, suppressed lines start to jitter and spike. You are coming back from the abyss, but you are still paralyzed, and you still have a plastic tube shoved down your windpipe. This is the critical window. I need you to wake up enough to breathe on your own, but I can't take the tube out until I'm sure you won't vomit and inhale it into your lungs, a complication called aspiration that can be fatal. I'm watching for the signs of life, a twitch of a finger, a grimace. I'll lean in close to your ear and say, "Michael, the surgery is over. Open your eyes, squeeze my hand." In that moment, you are in a state of emergence delirium. You are half animal, half human. Some people wake up fighting. They thrash. They try to pull the tube out. Their heart rate spikes to 140. Others wake up weeping, overwhelmed by a primitive sadness they can't explain. I reach for the reversal agents, Sugamadex or neostigmine. These drugs are the chemical key that unlocks the paralysis. Within seconds, your muscles wake up. You take your first independent breath. It's a ragged, gasping sound. You cough, you gag. It feels like you're choking because you are. I deflate the balloon on the tube and pull it out in one smooth motion. You won't remember this. The amnesia from the midazolam is still protecting you. But for those few seconds, you are fighting for your life, and I am the only one holding on to you. We wheel you into the PACU, the post-anesthesia care unit. You're shivering. That's the anesthesia shakes. Your body is trying to regain the heat it lost in that cold room. You're confused. You'll ask the nurse the same question 10 times. Is it over? Did it go okay? And the nurse will smile and answer you 10 times because she knows your brain is still rebooting. Like an old computer, your memory files are being reloaded one by one. But even as the fog clears, something has changed. You have just survived a trip to the edge of existence. You have been turned off and turned back on. And then there is the anesthesia hangover, but I'm not talking about the nausea or the sore throat. I'm talking about the emotional displacement. For hours or even days after you wake up, you might feel thin, transparent. You might find yourself staring at a sunset or a loved one's face and feeling a strange, hollow sense of mourning. This is the post-op ghosting. Your brain has rebooted, yes, but the software is glitchy. The chemicals are still leaching out of your fat cells, whispering to your neurons that the void is still there, just an inch away. You've touched the wall of the afterlife and come back, and your subconscious knows it. It's why some people cry for no reason in the recovery room. It's not pain. It's the sheer, overwhelming shock of existing again. You are relearning how to be a person. You are reintegrating the you that I shattered on that cold table. It takes time for the pieces to fit back together perfectly. Don't rush it. Respect the fact that you've been somewhere most people never visit until it's permanent. People ask me why I do this, why I spend my life in a windowless room, staring at green lines on a screen, taking on the stress of holding 1,000 lives in my hands every year. I do it because of the moment you wake up. I do it because when I see that spark of recognition in your eyes, when you realize you're alive, that you made it back from the void, I am reminded of how precious that spark is. We take consciousness for granted every single day. We walk, we talk, we love, and we think it's just normal. But I know the truth. I know how easy it is to take it away with 200 milligrams of a white liquid. I know how fragile the connection is between your spirit and your body. So, when you go under anesthesia, don't just think of it as a medical necessity. Think of it as a testament to the miracle of being alive. Know that while you are gone, someone is watching over you with a devotion you will never see. Someone who respects the mystery of who you are. You're going to be okay. We've done this thousands of times. We've built the bridge. We've mastered the chemistry. And when the surgery is over and the lights are bright again, I'll be the first person there to welcome you back to the world. If you have a surgery coming up, or if you've ever had a strange experience while under anesthesia, a dream, a vision, or a feeling you can't explain, leave a comment below. We need to talk about these things. We need to bridge the gap between the sanitized brochures and the forensic reality of the operating room. I'm Dr. Michael Kent. Thank you for trusting me with the truth. I'll see you when you wake up.